Einass?
Yes, sir. Uh, I'll
Yeah,
start,
start.
sir.
Yeah.
Uh, Good evening. The topic for today is corrosive injuries and other benign conditions of esophagus. First, starting with the caustic esophageal injury. Caustic ingestion can cause severe injury to the esophagus and stomach, and the pattern of injury depends upon the type of agents which are ingested. Alkalis, there are alkalis, acids, and which are typically ingested. And alkalis will cause injury to the esophagus and the stomach or the duodenum, whereas acids are more likely to be associated with causing severe gastric injury. And both acids or alkali can induce laryngeal and tracheobronchial injury as well. In terms of the epidemiology, it in most of the cases where associated with caustic ingestion are usually intentional. These are associated with the underlying psychiatric illness, especially in adults, with the suicidal intent, which is thereby associated with a larger amount of ingestion of these agents. Uh, uh, Apart from this, in children, they are usually ingestion is usually accidental. And going further with the common cause of ingestion is a strong alkali medium, which is primarily composed of sodium or potassium hydroxide. This is primarily seen in drain cleaners or other household cleaning products or disk battery. And whenever we use the term lye, this implies substances that usually contain sodium or potassium hydroxide, which are toxic. And in terms of acids, highly concentrated acids, this include hydrochloric, sulfuric, and phosphoric acid. This can be seen in the swimming pool cleaners or anti-rust compounds or in battery fluids. And therefore, the chances of these being ingested are less frequent. The liquid household bleach, which is present, consists of 5% sodium hypochlorite. This is frequently reported to be ingested, but this is a rare cause of causing severe esophageal injury. In terms of the mechanism of injury, both alkalis and acids will produce tissue injury by different mechanisms. Alkali-induced injury is, for example, if there is ingestion of ammonia or any product which contains ammonia or sodium hydroxide, this will resulting in a penetrating injury because of the mechanism of liquefactive necrosis. Here, the injury will extend rapidly within seconds through the mucosa and the wall of the esophagus towards the mediastinum till the tissue fluids will buffer the alkali. Therefore, alkali-induced injuries are associated with extensive transmural damage, and this can also contribute to esophageal perforation, mediastinitis, and death. In stomach, there is partial neutralization of these ingested alkali materials by the gastric acid. Therefore, the injury is more limited in comparison to when seen in stomach. And amongst patients with alkaline ingestion, gastric injury is more common in those who have ingested a relatively large volume of this substance, like roughly around 200 to 300 ml. This process of liquefactive necrosis, which is seen, will last usually for 3 to 4 days, result in vascular thrombosis and tissue ischemia, mucosal infection, and thereby contributing in sloughing and ulceration. And over the period of 2 weeks, the esophageal wall will gradually and progressively become thinner because of sloughing and because of the development of granulation tissue and fibrosis. And reepithelialization usually occurs, but it will take around, for the completion to take, it will happen in 1 to 3 months. And again, post this, the stricture formation will depend upon the depth of damage and the degree of collagen deposition. On, on the other hand, we have acid-induced injury. Whenever a person consumes acid solution, it causes pain upon contact with the oropharynx. Therefore, the amount of acid ingested usually tends to be limited. And upper airway injuries are more common with the ingestion of acid because perhaps because of the bad taste, which this will stimulate. and an attempt to spit out the ingested material. And in contrast to alkali solutions, alkaline solutions are more viscous, and acid preparation will pass more quickly into the stomach because of less viscosity, and therefore they are associated with causing less esophageal damage. As the acid will flow along the lesser curvature of the stomach towards the pylorus, the pylorospasm impairs the emptying into the duodenum, which will produce a stagnation. And therefore, the injury is particularly prominent in the antrum. And the food which is present in the stomach is also shown to provide a protective effect. Uh, Basically, acid ingestion will produce superficial coagulation necrosis, followed by thrombosis and again consolidation of connective tissue. This results in a formation of a protective eschar. Therefore, the injury induced by acids is relatively less in comparison to alkali. Uh, Going ahead to the determinants of severity, one of the main there are multiple factors like duration of contact, the corrosive property of the substance taken, the concentration and the amount ingested, and the form of agent. Uh, when The duration of contact with the mucosa is an important parameter, and upper airway injuries are more common, as said, with ingestion of acids in comparison to alkalis. And more the amount ingested and more the duration of contact, uh, corrosive property of the ingested substance. Wherein alkali, like we had explained, alkali ingested will damage the esophagus and acids will cause more severe gastric injury. And in terms of the concentration and amount ingested, the standard liquid household detergents have a pH ranging from 9 to 11. And therefore, this will rarely cause a serious injury unless this is taken in a large amount. Uh, Concentrated forms of laundry or detergent, like in forms of capsules or pods or gel packs, these are more concentrated and more likely to cause severe injury. And solid caustic, when we talk about the form of agent, solid caustic material tends to adhere to the mucosa and thereby can produce deep burns of the oral cavity and esophagus. And they are less likely to reach the stomach again because of the pain produced, the amount ingested is limited. Uh, Powdered and granular detergents will tend to injure the upper airway more commonly. And in contrast, like if we have liquid preparations or solid like preparations like disc or battery, they induce more localized injury to the esophagus. There are multiple ways of classification. First, looking into the pathological classification, uh, there is first degree, second degree, and third degree injury. In first degree injury, there is superficial mucosal damage, and thereby you will be seeing focal or diffuse edema, and hemorrhage. And the mucosal lining subsequently sloughs off without scar formation.
Einass? Einass? Hello? Hello?
We can hear you,
The
sir.
what?
Einass not heard now? Einass?
She is
Sir,
in
am I
the.
audible? Sir,
Einass, suddenly
am
you
I audible,
stopped.
sir?
No, you are now.
Sir,
Yeah,
I
yeah.
think, yes, sir. Sir, like, should I repeat this classification again, sir? Or,
No, you had gone to second degree transmural.
okay, sir. So again, like, transmural is a injury of the mucosa and submucosal damage. And thereby, there will be ulceration, exudates, and vesicle formation. There will be granulation tissue and fibroblastic reaction, which will produce a scar and possible stricture at a later date. Uh, the third degree injury is a transmural thickness, which is characterized by deep ulcers and perforation of the like the associated wall.
Yeah.
The other way of classifying these caustic injuries is based on the endoscopic severity grading. This is the Zargar classification. Herein, again, grade 1, 2, 3, and 4. 1 is superficial edema, 2A is mucosal and submucosal ulceration, 2B is deep or circumferential ulceration, 3A is transmural ulceration with focal necrosis. 3B will be the same but with extensive necrosis. And grade 4 will be perforation. These are a few endoscopic images. In the first image, this is grade 2A. So here the proximal esophagus is showing superficial ulcers with bleeding and exudate. So this comes in the category of grade 2A. Uh, the B image is the distal esophagus, which is showing circumferential ulcers and exudate all around. So this comes in the category of grade 2B. The third in the C labeled image is the gastric antrum, which is showing extensive necrosis and ulceration. This will come into grade 3B. And this is the least of all grade. So this is the duodenum which is visualized, and here the only mucosal edema and hyperemia is seen. So this falls in the category of grade 1.
Yeah.
Going to the clinic.
Stop.
Yes,
Yeah,
sir.
yeah. Yes.
Yes, sir.
Any questions so far? Anybody? New girls? Madhavika and Mahati? Any questions? Any clarifications? Speak up.
No, sir.
What about Likith?
No, sir.
Samir?
No, sir, nothing, sir.
Karthik?
Sir, nothing as of now, sir.
Okay. See, what Aina said about suicidal is correct, but the other thing is this: many times this could be a sudden reaction to some family, quarrel or love failure or whatever. It may not be necessarily person having a suicidal tendency. It's just a impromptu or a impulsive decision when they face some sudden rejection in love, or there is a major fight between husband and wife or friends or whatever, and suddenly they may decide to consume something. So it may not be necessarily always suicidal, but that angle definitely needs to be kept in mind, where it can be a planned kind of thing. Other thing is we have to be very careful about accidental ingestion, because small kids, you have to be at home, you have to be very careful to make sure that none of these obvious problems, batteries and the household cleaning stuff and acids and things which we use are accessible to small kids, because when you are not looking, because they are always interested in something that looks different, and then they may ingest it. So the onus here as far as kids are concerned is the parents, who need to be very extra vigilant about, especially naughty. If they have naughty children, you have to be very careful about leaving these stuff in the open, because if it is accessible to kids, they will definitely ingest it. Okay, carry on.
Yes, sir. Uh, Now, moving on to clinical manifestations, the clinical features will vary widely, uh, and the early signs and symptoms may not correlate with the severity and extent of tissue injury. So, the patients can come with complaints of oropharyngeal, retrosternal, or epigastric pain. There can be dysphagia, odynophagia, or hypersalivation. Other symptoms could be vomiting and hematemesis. Caustic injury to the oropharynx will cause pain and inability to clear the pharyngeal secretions. So these patients can also present with persistent drooling. Apart from this, there can be hoarseness, stridor, aphonia, and respiratory difficulties, however less common, as a result of caustic burns to the epiglottis and larynx. If the patient is presenting with fever, tachycardia, shock, this will imply there is a presence of a more severe and extensive injury. And persistent severe retrosternal or back pain is highly suggestive of esophageal perforation with mediastinitis. And again, the presence of persistent localized abdominal tenderness or guarding and rebound tenderness and rigidity on clinical examination are again suggestive of perforation with peritonitis. Uh, Complications primarily occur in patients with high-grade injury. In this, bleeding, that is upper GI bleeding, occurs in approximately 3% of the patients and will occur usually 2 to 4 weeks after ingestion. Fistula formation to the adjacent organ can occur at any time after if there is massive ingestion of strong corrosives, and usually if like a patients can have chronic tracheoesophageal fistula. This is seen in 3% of the ingestions, and usually they will present with frequent coughing following solid and liquid intake, recurrent bronchitis or purulent bronchitis or pneumonia, recurrent aspiration, and malnutrition. Aortoenteric fistulas are rare, accounting for 0.02%, and they are associated with the highest mortality. And apart from this, there can be stricture formation. This is the most common complication of caustic ingestion. And 1/3 of the patients who suffer from caustic injury will develop esophageal strictures, primarily those who will have high-grade injury. And the stricture formation is related to the depth of injury. This will usually develop within 2 months of corrosive ingestion, and it can occur as early as 3 weeks to a year after ingestion. And again, the patients usually present with dysphagia. Dysphagia primarily, and this dysphagia can result from caustic strictures, and this can also be due to the esophageal motility abnormality because like the scarred segment will have low amplitude peristalsis will be affected, and this will result in motility abnormalities. And the squamous cell carcinoma formation, up to 30% of the patients with caustic injury will develop esophageal cancer. The corrosive injury later in life is associated with a shorter latency period, and the carcinoma at the site of a previous stricture or scar carcinoma is associated with a better prognosis in comparison to the other causes of esophageal SCC. This is primarily because of early stage at diagnosis, as the esophageal lumen at the level of the scarred esophagus is less distensible. So the dysphagia will occur early in the course of disease, and thereby the presentation will be slightly earlier in comparison to other causes.
Other explanation may be, apart from what you said, which is very right, is the
Yes.
fact that these people develop significant amount of fibrosis and thickening, which may prevent the tumor from spreading.
Yes, sir.
So the prognosis may be better because of that.
Yes, sir.
Okay.
In evaluation, history and examination is one of the most critical point. And here we have to take a detailed history about the type of caustic agent which was ingested, the amount ingested, the time from ingestion, and also any associated co-ingestion of other drugs. Apart from this, physical examination Yes, sir.
Einass,
Yes, sir.
first of all,
Yes, sir.
all of you need to know, first thing is, as soon as the patient comes to casualty, the casualty people and you as a surgeon, first, apart from quick evaluation, you should be able to, give a first aid in such a way that you may limit the damage that the ingested substance may cause. So you have to quickly assess the patient, see if the patient is breathless, is he got stridor or difficulty in breathing and all those things, and address those things. And the patient sometimes will be in severe pain. So ease the pain of the patient by giving them good analgesics, and then you can take the history and other things later. But the important thing is to symptomatic relief and do a quick chest X-ray and an erect abdomen to ensure that there is no perforation before you may want to give them some the what do you call that? For example, for an acid, you give alkali, and for alkali, you give a mild acid to neutralize um, the effect of this substance that has been ingested. And if it is possible, um, quick endoscopy and sucking out all the fluids, the whatever has
Yes.
been ingested, once you have confirmed that there is no perforation, may be very important. So I think what you need to know is, I do understand importance of a detailed history and examination, but that those things can be done at a time once you have given the first aid and you have limited the damage of the ingested substance. So I think for example, when you face a patient with trauma, you ensure that the ABCD is taken care of quickly, and ensure that the airway, breathing, all those things are taken care of. Then you can take a history and all those things. So same thing applies here also. If you can do something to neutralize or limit the damage that has happened, especially if the patient comes quickly, as you said, the presence of these substances for a longer period of time will continue to damage the organs. So if you can suck it out, neutralize it by wash it out and all that, provided you have done that after ensuring that there is no perforation already. So that is the most important thing. Okay. So
Yes,
carry
sir.
on.
Yes, sir. Uh,
Any doubts or clarifications? Sania?
Nothing, sir. It's
Okay. Okay, carry on.
yes, sir. In examination, we should inspect the oro and hypopharynx, neck, chest, and abdomen. Uh, in oropharynx, we look for edema, erosions, or necrosis with grayish pseudomembranes. If the patient has respiratory distress, laryngoscopy is performed so as to evaluate the need for intubation. And patient with oropharyngeal injury should be closely monitored because there is a chance of them developing airway obstruction. Uh, and again, Even if there is an absence of oropharyngeal burns, this does not mean that there is no presence of significant esophageal or gastric injury. And any signs of gastrointestinal perforation, like rebound tenderness, subcutaneous emphysema, and hemodynamic instability, is an indication for prompt immediate surgery. Laboratory investigations will include a routine evaluation like CBC. Apart from this, which may mostly will be normal, but it might reveal leukocytosis. Apart from this, we look for the liver function test, serum lactate levels, and serum electrolytes as well. And perform also, in addition to this, performing a toxicology screening. Uh, a presence of leukocytosis, high levels of CRP, severe acidosis, low pH, high blood lactate concentration, uh, deranged RFT, indicative of kidney failure, deranged LFT, and thrombocytopenia are predictive of transmural necrosis and therefore are associated with poorer outcomes. Imaging, the primary imaging, if the patient is not hemodynamically stable, is to go ahead with an X-ray chest and X-ray abdomen. Here in the first image, we can see that there is a left hydropneumothorax. The second image is again after acid ingestion, which is showing pneumomediastinum with large pleural effusion over the left side. And the third one is an abdominal radiograph, which is showing pneumoperitoneum because of gastric perforation. If the patient is hemodynamically stable, then we can consider doing like we perform a CT scan of the chest and abdomen. This will provide better information in terms of the depth of injury necrosis. And primarily tell us about the depth and also indicate the site of injury. Apart from this, although barium studies are not done and may be mostly done at a later stage when the patient is presenting with symptoms associated with complications rather than the acute presentation. here are a few images where the first one is after one.
Einass,
Yes,
just
sir.
a minute.
Yes, sir.
Barium is virtually non,
Not.
I think ruled out now. Nobody does barium anymore. But
Yes, sir.
you are showing the figures. You can show what classical pictures look like. But
Yes, sir.
barium is no longer done. I think only thing that is used is water soluble contrast, which is gastrographin, which is used for
Einass, why you should not use barium, especially when you're suspecting perforation?
So it will add on to the
barium
severity,
is
sir.
very
Like it will
toxic, ma.
toxic.
Barium is
Yes,
very
It
sir.
can
toxic.
cause mediastinitis or it can produce
And
peritonitis that
Yeah.
itself if
yes,
it leaks. So nobody uses barium when you suspect
the
perforation,
toughness.
and
Yes.
especially in these corrosive or caustic injuries.
Okay, sir. Yes, sir. Uh,
Yeah.
I'll go. Yes, sir.
Yeah. Go to the next
Just to
slide.
come, I'll go to the next one, sir. Yes. So, CT is done. Just before going into the CT findings, there are gradings. If at all an emergency CT is done, uh, that it is classified into grade 1, grade 2, and grade 3 again. In grade 1, the organs will appear normal, and this will usually correspond to there'll be no mucosal irregularity, and this will mostly correspond to low grade, 0 to 2A endoscopic burns. In grade 2, mucosal irregularity will be present. There will be early structural changes, wall edema, and surrounding soft tissue inflammatory changes, as well as if at all contrast is administered, then there will be increased post-contrast wall enhancement. And this corresponds to more severe endoscopic burns. Grade 3 is either associated with a frank stricture formation, or sometimes it can also be associated with a fistula formation, which may be visible. And but these are rare scenarios. Primarily, grade 3 will show transmural necrosis, and in case of a CCT, the absence of post-contrast wall enhancement, and this is going to correspond to grade 3B necrosis on endoscopy. Uh, Again, these are the CT grades of acute corrosive injury. In grade 1, there'll be the normal wall thickness which will be seen, and there'll be normal enhancement. There may be motility changes because of which the esophagus may be dilated as shown in the arrow in B and C. Uh, in grade 2, there'll be wall edema, so the thickness will be more than 3 mm. And however, the serosa or adventitia will be normal.
There is no,
Apart,
hello. There is
yes,
no
sir.
serosa in esophagus, ma.
Sorry, yes, sir. Sorry, not serosa, sir. Like the adventitia will be normal.
Adventitia and muscularis. Yeah.
Yes, must
Okay.
be, sir. Yes, sir. And again, like the images that are seen from G2I, again, this will be associated with increased wall edema more than 3 mm of thickness. Associated with this, there will be surrounding soft tissue stranding, as we can see in the image H and I. And grade 4, again, there will be wall edema more than 3 mm, surrounding soft tissue stranding, and there will be loss of the surface interface, which will be seen. Like there will be a sharp loss of the surface, or sometimes it can be also associated with surrounding collection. Uh, in terms of the management algorithm, there is a broad classification where you see asymptomatic patients and symptomatic patients. And again, in symptomatic patients, there is a role of endoscopy, following which there will be conservative management or surgical management based on low grade and high grade patients. Uh, in all patients, the initial management
Just a minute
will,
first.
yes, sir.
As after you have confirmed that there is no perforation by either chest X-ray or a CT, as you said, you have to consider endoscopy as an emergency procedure, and
Yes, sir.
emergency has to be done by experienced person, and it should be done extremely carefully and with diligence, because you can yourself cause perforation in situations where there is already significant amount of mucosal injury, transmural or whatever, and then if you go through and it can cause, and you have to also use less amount of insufflation as you would normally do, because the more insufflation you do, you can blow out a injury which can become then perforation. So you have to be extremely careful, but the importance is that you have to do an endoscopy to assess the extent of injury, the site of injury, and then whether endoscopically anything can be done, or you can then make a decision about surgical intervention, as you said. So
Yes, sir.
endoscopy forms one of the most important assessment tools of caustic injury, but with the caveats that you have to have initially ruled out a perforation, and you have to do it with extreme diligence and care. Okay, carry on.
And how often
Uh,
you will repeat Einass endoscopy, and when will you decide on basis of what findings you will decide surgery?
Sir, so usually and
Are you coming to that? Are you coming to that? Are you
yes,
coming
sir.
to? So you
Uh,
finish the supportive care and then answer Niranjan.
yes, sir. Yes, sir. Uh, so, in terms of supportive care, general measures will include your respiratory support, fluid resuscitation, and pain management. Uh, and symptomatic patients are those with significant ingestion. Uh, we have to rule out mediastinitis or peritonitis, and it is necessary to keep the patients NPO. Nasogastric intubation, like NG tube insertion, to remove any remaining caustic material should be avoided, because it may either induce retching and vomiting, and this can add on to the existing injuries and contribute to perforation of the esophagus or stomach. Antibiotics are used in selected patients when we are suspecting perforation. These includes this will include broad spectrum antibiotics, and apart from that, there is no role of emetics, or usually these are contraindicated, because vomiting re-exposes the esophagus and the oropharynx to the caustic agent, which will further aggravate the injury. Neutralizing agents like weakly acidic or basic substances uh, should not be they are mostly nowadays avoided, because administration of these can damage, and this is generally instantaneous. And furthermore, neutralization releases heat. This will add on to thermal energy and further cause more destruction of the tissue, like the ongoing tissue. Uh, in terms of the role of endoscopy, upper GI endoscopy should be performed as early as possible, preferably within 3 hours of the patient presenting to us. And apart from that, it can be performed as late as 48 hours in order to evaluate the extent of esophageal and gastric damage, and thereby aid in further management. If there is any evidence of GI perforation, this is usually contraindicated. And in case if a respiratory distress is present, or if there is signs of oropharyngeal or a glottic edema or necrosis, the patient should be intubated for airway prior to performing an endoscopy. Uh,
Full tank petrol.
uh,
Petrol full
yes,
tank.
sir. And if at all upper GI endoscopy is delayed beyond 48 hours, endoscopic grading may be inaccurate because of the development of submucosal hemorrhages and edema. Therefore, it is essential that this be performed within 48 hours. And like Sir said, it should always be performed by an individual clinician who has expertise in this, because while performing this, these patients are more prone, or are at an increased risk of inducing perforation. And again, the Zargas classification is used so as to uh, give the endoscopic severity grading. In terms of subsequent management, if the patient is having low grade injury, if the grade is between endoscopy grade 1 or 2A or CT grade 1, we manage them with supportive care, pain control, and pain control. And apart from this, if we see no deterioration of the patient and clinical signs of improvement, then we further break the MPO status, start them on liquid diet, and then advance them to a regular diet within 24 to 48 hours. Uh, Patients with high grade injury will require inpatient monitoring for clinical signs of perforation over a 1 week period. Radiographic monitoring is not required, and endoscopic evaluation is considered if there are new symptoms, if the patient is developing, and at the end of 2 months, so as to see a certain mucosal restoration and to see the mucosal integrity. Uh, uh, and apart from that, again, surgical management, the indication will be either perforation or hemodynamic instability. And laparotomy is the standard procedure for in an emergency scenario. And sometimes, on rare occasions, there can be direct mediastinal extension because of the esophageal perforation, which will necessitate a thoracotomy approach as well. And apart from this, in case of an perforation, uh, like we the sir, I'm not sure about this. This I have just read that they use endoscopic vacuum therapy. So they are putting extraluminal and intraluminal sponge uh, with the aid of with the aid of endoscopy, so that they are preserving the esophageal patency and continuity. And they are doing this in patients who are very unstable to be taken up for surgery as well. But I'm not there is no documentation of how this is performed, sir.
I didn't understand, but you have to answer the question of Niranjan. What
Yes,
are
sir.
the indications on endoscopy of which will tell you that you have to go for surgery, and how often do you do endoscopy?
Sir, high grade, if the grading is high, sir, if it is going to 3A and 3B and 3-4 on endoscopy, that is an indication for, on endoscopy is an indication to do surgery. If it is 2A and 2B, then you will just do inpatient monitoring to look for clinical signs of perforation. And this monitoring has to be done for a period of 1 week. And relook endoscopy should be done if at all the patient is developing new onset symptoms, or if not, then we do it at the end of 2 months, so as to look for if there is mucosal restoration, sir, like if the damage is
No, but
reversed.
and as 3A, 3B, when will you consider, like, if it is 3A, 3B on initial endoscopy, you will immediately do surgery or you will wait?
So for 3B and 4, we have to surgically intervene, sir. 3A, we may wait and watch, sir, because
What
this
is
will be
3A?
focal necrosis. So 3A is focal necrosis with multiple ulcerations.
Hmm.
3B is extensive necrosis.
Hmm.
And 4 is proper. The 4 is perforation, sir.
No,
And
4
for
is perforation.
2B,
Perforation, you don't
that is
can't wait. What I'm
not.
asking is on endoscopy, when you do endoscopy, in perforation,
Yes,
you
sir.
will never do endoscopy.
Yes, sir. Yes, sir.
So why I asked you is I don't think we will do surgery immediately. We will wait for some time to because the
Yes.
injuries may that progress, that burns may progress. This is just
Okay,
an
sir.
initial finding. And
Yes, sir.
I don't think you do endoscopy and then keep quiet for 2 months. You probably have to repeat the endoscopy every week, one to break the synechiae, and then assess the at the end of 2 months. If you are waiting it out, why you have to wait out is how you will probably be able to save some amount of stomach, or actual assess the extent of the disease at the end of 2 months once the burn, wounds, everything heals and fibrosis happens and all those things. So then you will be able to take up the plan of accurate management. Sir, do you
Correct.
Um,
Yeah,
out for
correct.
2 months without doing endoscopy,
No,
or you
correct.
do endoscopy every week
No,
to
correct,
break the
correct.
cycle and assess the fresh findings and
Yeah,
dilate it? Endoscopy itself will be a kind of dilatation.
Validation. You're absolutely right. That is why I wanted you to answer that question, Ainas. That
yes, sir.
once you decide to conservatively manage these people, you obviously have to know how things are progressing or they are not. So you have to
Yes, sir.
repeat the endoscopy depending on the clinical stage of the patient, which usually translates to every week. So every week the patient is either inpatient or as if the patient has been discharged, you call them for regular assessment. It's unlikely that you would have discharged 3A, 3B patients that early. So you have to do it once when they come and then once in the next week to see how things are progressing. And then obviously if there is deterioration, then you have to make a decision about whether to intervene or not.
And
So
you
whether,
probably put a NJ tube in the same time when you do
correct.
the endoscopy. So
So
like
Yes.
feed them.
So you don't put NG tube as you said rightly blindly, but under endoscopic guidance you can then pass this tube into the jejunum and then because instead of doing an operative jejunostomy, you can do a
Yes.
nasal jejunal because even radiologists will not be able to help you in this because there is already injury in the esophagus, so they can't do it. So only way to doing this is to endoscopically placed nasojejunal tube so that you can feed these patients comfortably without any problem.
If due to some
Yes.
reason, if you're not able to put that, then the only option left will be do a feeding jejunostomy, either
Surgical feeding.
laparoscopy or open surgical feeding jejunostomy.
Yes. Yeah.
Yes, sir.
And
Sir, so,
what you mentioned was correct with respect to vacuum therapy. I have read about it, but I have no idea how they put it inside. But that is what they say in probably in the US and all that. I don't know how it works, and I don't think whether we have the expertise to put it in our setting in India.
So
yes, sir.
what you can do is to
It
ask
works with the same principle, like vac.
ask ask Purna Chandra if he has any experience with it or if he has seen it or if he knows about it so that we can learn about it. I haven't, as
Oh,
Niranjan said, I haven't seen it, so I can't confidently tell you. But
yes, sir.
it may be worthwhile speaking to Dr. Purnachandra, and once you have done it, put it up in the group as to how it is done, what are the indications and all that. Okay?
Yes, sir.
Yeah.
Yes.
Carry
Sir,
on.
yes, sir. So before management of complications, sir. So if we have an esophageal stricture, we will wait. I had this doubt, sir. So now we'll wait for 3 to 6 weeks, and then uh, do the dilatation, sir. Or like we are doing serial, like every week, like you said, sir, do endoscopy, and then we are keeping on dilating, sir.
Correct.
Uh, like that only, no? So like every week you do it, and like not to wait till 3 to 6 weeks post injury to wait for the stricture formation to happen and then dilate, sir.
So, as Niranjan said, it is you have to customize these things. You can't. There is no hard and fast rule. But the important thing is that you don't leave it till 2 months and then say I will only endoscope after 2 months. So that is
Yes,
the
sir.
important point. Then the other things will be depending on how the patient progresses and if there are no other complications or no other problems, then you have a relook endoscopy within the end of the first week or so to see the situation. You will be in a better position to assess the situation then, and then you can repeat the endoscopy depending on the condition of the patient, maybe the next week or the week after, and then as break the sinus and do gentle dilatation with the scope only. We don't try to do balloon dilatation or all those things because you may the tissue healing would not be complete by then. So if you try to do anything very heroic, then you may create a perforation. So what you have to do is to just do a gentle endoscopic dilatation just with the scope itself, and that should be sufficient. If stricture forms at the end of 2 months, as you said rightly, and then you start doing the dilatation with balloon dilatation, pneumatic balloon dilatation or bougies. I think nobody again that can be done, but I think balloon dilatation is much more what is now being done. So balloon dilatation is better.
Yes, sir. And sir, about surgical reconstruction, we should wait for 6 months and then do the reconstruction.
Correct.
Yeah, yes. Uh,
So surgical reconstruction, first of all, you have to ensure that the pulmonary complications are taken care of, nutrition is taken care of, and all those things, and then allow for you to assess the status of the stomach, the status of the esophagus, and everything, and then make a decision about whether for example, if entire esophagus is strictured or damaged, as you said rightly, squamous cell carcinoma developing in them is high, so you may have to decide to do a esophagectomy. So then you will have to decide what is the conduit you are going to use. So that again depends on whether the stomach is available, stomach is also damaged or not. If it is an alkali injury, the stomach will be available, as you said. If it is an acid injury, the stomach obviously will also be badly injured. You may have to even reset the stomach. So for you to make all these decisions, you will need time. And patient also, many of these people are financially not very viable. Many of them are from low socioeconomic strata. So, again, for them to find they would have already exhausted their, financial resources because of the repeated dilatation and other things. So you will have to wait for them to arrange all these things and then consider. So both in terms of physiology of the patient and also, unfortunately in our country finances do play a role. So you have to wait for till such time that everything is falling into place before you do the surgery.
Yes, sir. Uh, I'll go ahead, sir.
Niranjan, anything to add? Hello? Niranjan? Students, Sanya, anything to add?
No, sir. Nothing. I think everything is covered, sir.
Karthik,
Sir, nothing, sir.
students, any doubts about how to manage this? You understood the role of endoscopy, when to do it, when not to do it, how to do it, everything? Malavika,
Yes, sir.
Likit, understood?
Yes, sir. Yes.
Okay, right. Yeah. Samir,
Sir, just one doubt, sir.
ah,
Sir, they like on studies they've told that third day to second week it will be the ulcerative phase. So
ah.
any invasive procedures, any endoscopies should be avoided at this time.
So that's what I said. Basically, first of all, as the patient comes, you ensure that there is no perforation by doing either a chest X-ray, abdominal X-ray, or a CT if needed. And if you're sure about it, do an endoscopy. Then you can assess the immediate damage. You can also aspirate whatever the contents there are in the stomach, and also consider, as Niranjan said, passing a nasojejunal tube for nutrition. So that much is clear, right? Are you
Yes,
clear
sir.
about that? Yeah.
Yes, sir.
Then subsequent endoscopies are decided. I think Niranjan also said that very clearly, that you don't have a hard and fast rule, but you don't wait till 2 months. So what you do is, depending on how the patient progresses, depending on the CT grading and endoscopic grading, then you can consider repeat endoscopies, uh, depending, individualize or customize the repeat endoscopies. Follow?
Yes, sir. Yes. Okay.
Okay. Right, carry on.
Yes, sir. Yes, sir.
Sir,
Uh,
just
uh,
one small question, sir.
Ah,
Sir, in case while during doing the endoscopy
ah.
for the assessment, uh, if the perforation happens, then sir, how to manage it? Like, do we have to take up a surgery and do a repair then and there, or
Obviously, if there is perforation, you have to, but that is why I told you, you have to be extremely careful about. I think even Einass mentioned it. The moment you encounter a circumferential ulceration, you have to stop there. You can't go further.
okay,
So that is why a very experienced endoscopist is necessary. Very gentle handling of endoscopy is necessary. Not enough insufflation, because you don't want to insufflate and cause perforation. So a lot of diligence is necessary when you do an endoscopy. But it is necessary because that is the best tool of assessment of the extent of injury. So it is a balance you have to identify. If, for example, there is perforation, you obviously deal with it as perforation, because if it is a the thoracic esophageal perforation, obviously then uh, it depends on the size of the perforation. You can manage it by still going ahead and going into the stomach and assessing the extent of the injury and all that, and passing a nasojejunal tube, probably a tube which will aspirate the stomach contents also, and then in addition give feeding. And so this triple lumen tube, if you have it, along with it, what is called as the Bengmar tube, you can pass that. Or and it is not necessary that all perforations have to be, if it is a tiny perforation, there is a risk of mediastinitis. You can conservatively manage them by giving heavy duty antibiotics and chest physiotherapy and all that. But there is, again, if the perforation is big, you cannot wait, you have to operate. Treat it just like a perforation you already encountered. So that is why it is important to not create one, but occasionally it may happen. You are right. Right, carry on.
Yes, sir. The pharyngoesophageal strictures, they will require retrograde dilatation, and if at all this dilatation is not possible, then the management will involve surgical reconstruction either by colonic interposition or using a mucocutaneous flap. Similarly, if there are multiple failed attempts for endoscopic dilatation, even for an esophageal stricture, that is when we have to evaluate for reconstructive surgery. There should be a yearly surveillance, annual surveillance, endoscopy surveillance in these patients because they are at a higher risk of developing esophageal cancer. And after a period of 10 years, the latency period is 20 to 40 years. And after a period of 10 years, we can decrease this surveillance to every 2 years. This is the standard recommendation. Going in terms of surgical reconstruction, looking into the conduits, so the reestablishment of any gastrointestinal continuity is critical, so as to maintain the quality of life. And when we talk about an ideal conduit, it should mimic all most of the functions of what organ is being replaced. And so basically, the essential parameters are that there should be a sufficient length so as to bridge the gap within the gastrointestinal tract. There should be a good vascular pedicle, which will allow maintenance and perfusion along the entire conduit distance. And this should provide more than sufficient perfusion to the distal end so as to not cause any anastomotic problems, such as anastomotic leak or vascular compromise, and also stricture. And an ideal esophageal replacement should also have intrinsic motility so as to facilitate the transit of food boluses and to ensure that the reflux is minimum. Currently, there are various options that are available for esophageal replacements. This will be the stomach, the right and left colon, and the jejunum.
Hello? Hello?
So, and however, there are certain instances when the stomach is unavailable for use, as mentioned before also, like prior history of caustic ingestion where both the esophagus and stomach are injured, any oncological unfeasibility, like gastric extension of the distal esophageal tumor or because of GE junction tumors, any prior history of gastrectomy, if the right gastroepiploic artery is compromised from a previous surgery, and failure of a previous gastric conduit because of ischemic necrosis, stricture, or any de novo malignancy. All of these are conditions wherein you will not consider stomach as a conduit. Then the other two options which were mentioned, colonic interposition and jejunal interposition. Colonic interposition was used in the early 1900s for esophageal reconstruction. And we can use the left or right side, but preferably the right side because of its vascularity and the easy access to its length and limited redundancy. However, both are used, and in either case, transverse colon is always required. And the reason for preferring right colonic interposition is that it closely stimulates the native esophagus. It is resistant to acid, and also in case of a right colonic right colonic conduit, they have this the valve of Boehm, which will aid in decreasing the reflux. Again, which will act like the original esophagus mechanism. The disadvantages of colonic interposition include that the colon can have or may develop a native pathology, which can contribute to loss of absorption capacity of the colon, and ultimately may result in diarrhea. And the colon conduit also has a propensity of lengthening over time. This will result in redundancy and then may require surgical revision. Apart from this, we all preoperatively we have to make sure that we have to do a CT so as to look at the vasculature. Make sure to rule out ischemic colitis or Crohn's or ulcerative colitis before we go ahead with this procedure. This can be done by doing a preoperative colonoscopy, and CT and arteriogram is also necessary so as to ensure good superior and inferior mesenteric arteries, the ileocolic, right, middle, and left colonic arteries uh, uh, should be ensured. And when we are seeing the technical consideration, we have to make sure that the entire colon is mobilized, the mesentery is splayed and transilluminated. The middle, right, and ileocolic connections are clamped to ensure the viability, and then you ligate them proximally. After this, the usually the graft, the ascending colon is transected just above the cecum, and again here the colonic graft can be positioned in the posterior mediastinum, retrosternal, or stubsternal. Preferably, the posterior mediastinum is most commonly used. Following this, we can go ahead with the anastomosis of the conduit. In jejunal conduits, the jejunal conduit was again in 1946. Longmire had in early 1900s is when they tried attempting to use jejunum. And in 1946, Longmire proposed a vascular augmentation of jejunal conduits. This is what this is what is known as supercharging, so as to enhance the vascular supply of the conduits and to decrease the risk of ischemia. Again, jejunum is also considered a good conduit because of its reliable blood supply, and which can be enhanced because of this technique. There is also a significant amount of redundant jejunum, so the patient will not be harmed because of the loss of the length of jejunum, and the jejunal intrinsic pathologies of the jejunum are less likely. So again, this makes it as an ideal conduit. The disadvantages are that this like a supercharged conduit will need microvascular anastomosis, again, which will add on to operative time and technical complexity. And apart from that, the jejunal conduit sometimes may not be long enough to reach the hypopharynx. And this is they also have an associated fatty mesentery. So this will not allow the surgeon to easily pull up the conduit. In terms of technical considerations, we have the jejunum is selected 20 centimeter from the ligament of Treats. The first jejunal arterial branch will be preserved. The second branch is divided. And this is with an intention of using it to augment the vascular supply of the graft in the next. And the third branch is also divided. the fourth jejunal branch is preserved to supply the rest of the conduit. And because of the shortened mesentery, the mesentery must be divided to straighten the conduit and further prevent the redundancy. Again, we pull it up either in the posterior mediastinum and then uh, go ahead with the anastomosis. So I'll go ahead to esophageal perforation, sir.
Yeah.
Uh,
I think
so
you can't. I think wait. See,
yes, sir.
esophageal perforation is an important topic, and it's already 10 o'clock. So you will have at least 15 minutes or so of this.
Yes, sir. And after this, there is foreign body ingestion and
Yes.
as well, sir. Two topics are there, sir.
So we can club it with something else. I think because usually, as I said, first thing is the attention span is only 30 to 45 minutes, and two, it's
Yes, sir.
already 10 o'clock, and if you continue for another 15-20 minutes, it will be twice the amount of attention span. So we'll stop here. We'll combine this with some other thing next time.
Yes.
Okay. So, anybody doubts or questions to Ainas? Did you all follow the nuances and the principles of the conduits, the stomach, the jejunum, and right colon? All of you read up about it. I think it is very well described in main course abdominal surgery. All of you read that. Or Mastery of Surgery by Robert Condon and Nyhus. Now I don't know who is. I think it is. What is his name? The textbook, not Sabiston, the other one. Which is the other big textbook?
Fisher.
Huh?
Fisher.
Not Kusheri, the other
Schwartz.
one.
Schwartz.
Schwartz.
Sure.
So
Schwartz.
Mastery of Surgery is now edited by somebody from Schwartz, I think. So if you have the latest edition, look at that. Otherwise, abdominal surgery by Main Go will have given you this. Read it up nicely. I think it is all the advantages, disadvantages of different conduits are very well in this one. So read up. Okay.
Yes. Yes.
So Karthik, what did you think of the class? What did you think of Ainas's presentation?
Sir, it was a very good presentation by Einass, sir, and slides were very good, and learned a lot from this class, sir.
What about Samir? Samir, are you there?
Yes, sir. Yes, sir. It's a very nice class, sir.
Sanya and Nikita.
Nicely done,
Sir,
sir. Even the PPT is very well made.
she
Nikita?
explained things very detailed, sir. Yes.
Okay. Niranjan, final comments?
Well done, sir.
So I think it is a tough subject, and she has actually done a very good job. She's, I think the main thing, as all of you should notice, one, the quality of slides and the presentation was good. She was not reading the presentation. That is very important. You have to develop this very early in your career, not just copy paste and read from that. So whatever Dr. Lakshman said about the quality of slides, number of lines per slide, number of words per every sentence, all of these things were well maintained, and she was explaining it rather than just reading from the slide. So as so Dr. Lakshman has given you the thing, basically initially what you have to do is to use the PowerPoint presentation with the notes is there. So you can write in the notes whatever you want to say and then read it. Others will not know that you are reading because it is hidden. So put up the bullet points, important points in the slide, and while you are explaining, use your notes to read or talk from the notes. So that way initially you can prepare, and then later as you become better and better, you may not need the notes. Okay, so I think you have done a good job, Einass. Good night, all of you.
Thank you, sir. Thank you.
Good night.